Hello and welcome to Heart Matters Live. I'm Fergal McKinney, Head of British Heart Foundation, Northern Ireland. Welcome to our new series of live Q&As where you'll hear from our panel of experts and get the chance to ask them your questions. Every 3 months, we'll be bringing you a jam-packed session centred on a different heart or circulatory condition. And today, we are focusing on heart attack. In the UK, someone is admitted to hospital due to a heart attack every 5 minutes. In the 1960s, more than 7 out of 10 heart attacks in the UK were fatal. Now, thanks to life-saving research, more than 7 out of 10 people survive. Today, we'll be joined by BHF-funded clinical researcher, Dr. Michael McDermott from the University of Edinburgh, who's going to talk us through some exciting insights from his research into identifying individuals at risk of heart attack. We'll also be joined by senior BHF Dietician, Dell Stanford. I'll be putting some questions to Dell shortly to find out ways that can help you lower your risk. But first, I'm delighted to introduce Helen Wilberforce, who, after having a heart attack in 2023, has since taken measures to improve her heart health and reduce her risk. Helen will be interviewed by Yana Theodoro from the BHF Research Engagement Team. If you've any questions for our 3 speakers today, please submit them via the Q&A function throughout the talks, and we'll put them to the panel at the end. Without further ado, welcome Helen and Yana. Over to you.
Hi, Helen. How are
Hi.
you?
I'm fine, thank you.
Thank you so much for being here and talking to us about your story today. We really appreciate it. To start us off, why don't you talk us through just a little bit about yourself, where you're from, what do you do?
I'm 74. I'm from West Yorkshire. I live in Holmfirth, which might resonate with some of you as last of the summer wine country. I used to be a teacher and then a local authority advisor and inspector, and I'm now retired. And 2 years ago, I had the completely unexpected heart attack.
And can you tell me a little bit about how your health was before your heart attack?
Well, I thought I was really quite healthy for my age. I went to my GP checkup appointments and everything seemed to be okay. Having said which, my father died at 42 when I was 3 years old from a coronary thrombosis. And I knew I was overweight. I'm 5'0". And at the time I was obese. I was 11 stone 7. And I did actually get breathless walking uphill, but I thought, well, that's just my age. I had one minor episode of, well, I thought it was minor, episode of high blood pressure when I was on holiday abroad, and I did see my GP about that. We followed it through, and I don't think either of us thought anything was to worry about, really.
And then what happened the day of your heart attack? Can you take me back to that day? Where were you? What were you doing?
Yeah, so I was in the Lake District. My husband and some friends were doing a fundraising sponsored walk. And I was the driver because I didn't like walking because, as I just told you, I got breathless. So I was on that day looking forward. Well, the previous day I was looking forward to spending a day in Windermere and Bowness, if you know that, in the Lake District. But I woke up just feeling odd. I just didn't feel right. I couldn't put my finger on quite what it was. I'd arranged with my friends that when my husband and friends went off walking, I would go to their house to pick up a parcel. So I drove to their house, no problem driving, but I didn't feel right. I got to their house and they have a very steep driveway, not long, but very steep. And I was actually struggling to get up it, feeling breathless and agitated and a little bit of discomfort in the middle of my chest, maybe, but I wouldn't call it pain. And by the time I got to their house, I decided I was going to go on my phone and Google female heart attack. I have no idea why, what the motivation was there. But I Googled female heart attack and it showed me a series of bullet points, the site that I was looking at. And it said, if a few of these symptoms apply to you, call 999. But I actually didn't want to call an ambulance. I wanted to talk to somebody about it because I was actually feeling uncomfortable being on my own, which is not me. I was looking forward to that day in Windermere and Bowness. So I rang 111. And by the time I rang 111, I was actually not really thinking straight, and I was aware of that. And the operative came on and I said, I don't really know what to say to you. I've just Googled female heart attacks. And she said, just one moment, I need to call over a clinician to come and listen to your answers to the questions I'm going to ask you. And quite quickly, because I was losing words, the clinician came over on the line and said, I'm going to call the paramedics. And they arrived quite quickly. They did an ECG, electrocardiogram, and I had what's called a non-STEMI heart attack. Don't know what that stands for, but it didn't really show up on that. And because I was losing words, I couldn't think of the phrase for blood pressure. I think that the paramedics probably thought I was having a stroke or a transient ischemic attack, something along those lines. And they made the decision to take me into A&E in Lancaster, which isn't my local A&E at all.
What happened when you got there?
Well, I got there and they very quickly took me in to have an MRI scan because their prime suspicion was that I might be having a stroke. And a little later, I was sent to have a blood test, chest X-ray, and another ECG test. A&E was very busy. I was aware that there were lots of people in trolleys in the corridors, and the consultant came and found me, called my name out and took me straight into a bay. And I was quite puzzled by that because I seemed to have bypassed the system. So I made some flippant remark to him and he said, yes, this is for you. You've had a heart attack, which was a real shock to me because I hadn't had any pain. And I still thought that, heart attacks involved pain. Shall I go on?
Yeah, go for it. What happened next?
I spent 30 lovely hours in A&E because guess what? They didn't have a bed. When I finally got up to the cardiac ward, I was there for a couple of days. They did an echocardiogram on me, and the operative and again the consultant both told me that my heart looked quite healthy. So things were looking good, really. I thought probably wasn't a heart attack, perhaps I got that wrong. But I do know that I learnt the phrase high levels of troponin, which is apparently definitive. I had a heart attack. And I was quite quickly told that I could go home the following day to Huddersfield. But they would like me to call in at Blackpool because there I could have an angiogram. Which I sort of knew what that was. And I said, yes, my husband will take me. And they said, oh, no, you're going in an ambulance with a paramedic with you, which seemed a bit strange. So I duly had my angiogram, for which people probably know you're sedated. And I came round from that sedative and the what I later found out was my cardiac consultant was next to me saying, there's no easy way to tell you this. I'll come straight to the point. All three of your coronary arteries are blocked, 80%, 90%, 90%. The only solution is a triple heart bypass. And I said, okay, because I'd been sedated, and I found it all a little shocking, really.
And how did you sort of process that? Well, first the diagnosis of heart attack, and then the fact that you were going to need a triple bypass.
I didn't realise the seriousness immediately until I told my husband, who was waiting in the waiting room, and looked at his face. And I was quite quickly taken up to a ward and told that I would have a triple heart bypass within the next 2 weeks. I don't think I cried at all in those 2 weeks. I think I was shocked, stunned. This wasn't my image of myself. I was healthy. Why was I in hospital? Obviously, they put me on various medication, and I was on telemetry, which I'd been on in Lancaster as well, to monitor what was going on exactly with my heart. And I just focused on the practicalities, really. I think looking back, I was probably in the beginning, the early stages of post-traumatic shock stress syndrome. But I focused on the practical. I read all the British Heart Foundation leaflets that were displayed in the hospital at Blackpool. So I became a bit of an expert on hearts. Well, not a proper expert, but you understand. And I changed my diet. I decided I was having no fats or anything. I was quite shocked to overhear people in the cardiac ward asking for large portions. And one lady who was waiting to go home couldn't wait to call in the pizza place to pick up a pizza, which I knew wasn't the right thing to be eating if you're a heart patient. So I changed my diet. I focused on the here and now. I'd seen triple heart bypass on these wonderful programs you can see on the television, so I knew what to expect. Also, I'd read my British Heart Foundation leaflets, and the hospital itself had a very good leaflet. So I think I did the right things within limited parameters of what I could do. I walked around the ward a lot.
It sounds like that moment was a real sort of like wake up call for you, and you sort of changed your attitudes from that point. And like you've already mentioned, sort of changing your diet, but like what sort of measures did you take from that point to improve your health and reduce your risk? Because of course, you know, once you've had one heart attack, there's always a risk that you could have another, but you've massively reduced that risk, haven't you?
Yeah, I think my focus was, I've just had new coronary arteries presented to my heart. I better keep them clear. So that was the motivation for the diet. And also, I'd tried to lose weight before, but I didn't have any motivation. But when it's a matter of life and death, which it was, you know, if I want to stay alive, I need to keep my coronary arteries going. So I have no ultra processed foods. I don't have sugar at all. That's a lie. You know, if somebody offers me a biscuit, I'll have a biscuit, but I don't use sugar in cooking. I don't use salt in cooking. I cut all the fat off meat. I eat a lot of fish. Twice a week I have fish, twice a week vegetarian, red meat maybe once a week. And I have much smaller portions. I'm eating to keep healthy. I'm not eating to enjoy food. I do enjoy it. It's possible to enjoy different food, but I'm trying to focus on keeping me alive.
And how do you
And
feel?
I also walk.
Oh,
Sorry.
yes, I've heard about your walking. And how do you feel now that you've made these changes? And, you know, if there's somebody who's watching who might be in a similar position to you, sort of what advice would you give to them to reduce their risk?
to follow all the advice you're given. I think we tend to ignore the good stuff that we're told because we don't want to hear it. So it doesn't sound good changing your diet, but actually I'm not on a diet. I've changed my diet to keep myself healthy, and I've changed the way I live. I walk. Most days I walk 2 miles going into our village and back up the very steep hill because I live in the Pennines, so it's all good exercise. Twice a week we walk between 8 and 11 miles. I did go last year for a 74-mile walk, but that wasn't all in one day, so don't panic. That was over a series of days, but that keeps me motivated. And in September, I'm going to do a 60-mile walk over 7 days. But in order to do that, you have to stay fit. So having started walking a lamppost at a time, I now enjoy clocking up the miles.
Amazing. Well, thank you so much, Helen. Yeah, it's really incredible the way you've, taken all the steps that you can to try and improve your health. Thank you so much. I'll hand back over to you, Fergal.
Thank you, Helen and Jana. And Helen, thanks so much for sharing your story so openly and honestly. Our next speaker is BHF-funded clinical researcher, Dr. Michael McDermott. Mike's research aims to identify individuals at risk of heart attack. He's the expert, so I'll let him tell you more. Welcome, Mike.
Thank you for the kind introduction, and thank you to the British Heart Foundation for inviting me to give this talk. And I think just before I do that, I would like to thank Helen for being so brave and telling us her story and sharing her journey. Now, from having heart attacks to preventing heart attacks, I'd like to focus on some research that I've done during my PhD. So my name is Michael McDermott. I am a British Heart Foundation funded clinical research fellow and cardiology registrar working at the University of Edinburgh and within NHS Lothian. Now, I have picked this picture, which is in Glencoe in Scotland for a number of reasons. One is because I wanted to show that it sometimes is sunny in Scotland. But two, like this hill, which is very high, preventing heart attacks is an uphill battle, and it's something that I deal with on a daily basis in my working life. So before we start talking about how to prevent heart attacks, I thought we could maybe just give a quick overview of what a heart attack is. Well, a heart attack is caused by a sudden reduction or blockage of a blood vessel, which reduces the flow of blood to the heart. It's a medical emergency, and without treatment, it can cause death, heart failure, or other cardiac complications. Importantly, it is preventable. So, why do heart attacks happen? Do they happen out of the blue? Well, for some patients like Helen, they do, but the more we understand heart disease, the more we realise that there's actually a very long process where the heart arteries, which begin as normal when we're born, over the course of our lifetime, they can become built up with plaque. Now, plaque is a mixture of things, but the primary ingredient within the plaque, or the primary constituent, is cholesterol. Now, cholesterol gets into our body in a number of ways. One is it's produced by the liver on its own accord, but often it's produced by our diet, or it's found in our diet. There are a number of risk factors that make us more likely to develop heart disease, and these are high blood pressure. They are having high cholesterol, which can be genetic, and it also can come from our diet. We know that obesity, smoking, and diabetes are also associated with increased risk of developing plaques throughout our life. And as we understand climate change and air quality change, we also know that it can be a significant driver for heart disease as well. How can we prevent heart attacks? Well, I've divided this slide into two sides. On the left-hand side in green, it's factors that patients or individuals can do, and on the right-hand side, it's over to the physicians or the clinicians with a view of trying to keep us healthy. Now, as Helen said, she said she's a heart patient and she must make some changes in order to minimise her risk of future heart attacks. And I agree wholeheartedly with Helen, but I might challenge her to take that a step forward and say, everybody who wants to prevent having a heart attack should try and adopt a healthier lifestyle. We know that being just a little bit more active per day reduces our risk. We know that maintaining a healthy weight reduces our blood pressure, reduces our risk of diabetes, and the sequelae that comes with that. We all know that eating fruits and vegetables, pulses and grains is much healthier, and yet often, for convenience or for other reasons, we often do eat unhealthy foods. And these tend to be foods that are high in saturated or trans fats. And I know that Dell's going to maybe cover this in a little bit more detail, so I'll try and not focus on that too much. And the other things that we've been really good at in the last sort of 10 to 15 years is stopping smoking or abstaining from smoking. Now, at the other side, with the physicians involved, getting your blood pressure checked or your cholesterol checked is something that I would advocate that everybody does, and it's not something that I would wait till you're in your 50s or 60s for. But you know, the process of heart disease builds up over many years, and it's not something that happens overnight. So current guidelines would recommend a blood pressure check every 5 years in your sort of late 20s, early 30s. A one-off cholesterol check when you're in your 30s to see what your level is, trying to avoid any obesity and early detection of weight gain. And ultimately what we want to do is detect patients who are high risk of developing heart disease or cardiovascular disease as a whole, so that we can instigate lifestyle changes, but also if we need to start medication that can help prevent heart disease. Now, one of the challenges that I face in my working life is that when people come to see me without symptoms, they feel well, they're on no medication, and that's a badge of honour. They don't want to be somebody who starts taking medication, and it's something that is often the reason why people don't want to be on preventative medication, and they feel that they have to be on them forevermore. And we have a long discussion for some patients that's not necessarily true. So that's how we prevent the heart disease just now. But I just want to focus on a little bit on how we detect patients who are high risk at this moment in time. So at present, we take into a number of factors. So we take into consideration somebody's age, their sex, their cholesterol, their blood pressure, for other medical problems, and their family history. And we feed that all into a calculator, and it generates a number at the other side, and it gives us an idea of what chance someone has of having a heart attack over 10 years. Now, the numbers that we tend to give patients can vary between sort of 1% up to about 30 or 40%. And for many patients, they hear those numbers and they think they're not very high. Now, most risk calculators have a cutoff of about 10%. So when your risk of a heart attack is 10% or more, then we would tend to think about recommending preventative therapy. But when you tell somebody that their risk of a heart attack is 10%, they hear that they've got a 90% chance that they won't have a heart attack in the next 10 years. And that can sometimes be a challenge to overcome, and sometimes both clinicians and patients can misinterpret this risk score. As a result, many patients feel that they are actually healthier than what they are. So we thought, can we do better? Can we assess patients' risk and identify heart disease earlier? So within Edinburgh, we've been undertaking a research scan. It's called the Scott Heart 2 study. And it is a randomised trial or a study where we take patients and we randomise them to have the standard of care, which is the risk score, or they get randomised to have a heart scan. And with a heart scan, we can see the heart arteries and we can see whether or not there's any disease present. And on this slide, this is a heart scan. The technical term is a CT coronary angiogram. And what we can see here is the heart muscle just running down beside. I'll just see if I can use this pointer actually. We can see that the heart muscle here, it's got a heart artery that's just sitting on it here. And the good thing about being a cardiologist is a lot of the tests that we do, we can see problems really straightforward. And you don't need to spend a lot of time at university or at medical school to understand that these bright white spots here may not look normal, and indeed they are not. This is the build-up of coronary artery plaque. And we can see here that it runs almost the length of the coronary artery. And this scan was taken in somebody without any symptoms at all of heart disease, but actually had quite significant heart disease all the way down one of the main vessels of the heart. And when we see that, we would recommend preventative tablets and medication. And as part of my research study, we wanted to understand what impact having a heart scan might have on somebody's health behaviours or lifestyle. We wanted to understand whether or not they were more or less likely to take medication, and we wanted to see what impact that would have on them as an individual over the course of 6 months. So in our study, we had middle-aged adults, so anyone aged between 40 to 70 with a risk factor for heart disease. We took them and we randomised them to CT scan or to cardiovascular risk scoring. And we used the current thresholds that are used in clinical practice. So if your risk score was less than 10%, then you had a one-on-one consultation with a physician. So that was myself or one of my colleagues. And we gave lifestyle advice that was tailored towards your lifestyle in order for you to live as healthy as possible. If your risk score was 10% or more, we gave the same lifestyle, but we also recommended medical therapy to the patient and their GP. In patients who had a heart scan, then there was a number of different outcomes that they could have. So first of all, everybody got lifestyle advice. In those who had some minor or mild disease, we also recommended preventative therapy, normally with statin medication and an aspirin tablet. Or if they were found to have significant heart disease, then we would give them intensive statin therapy and aspirin tablet, and we actually saw them back at the clinic just to see how we were doing. So everyone got the lifestyle advice, and we wanted to follow up to see what impact it had on their physical activity, their diet, their weight and BMI, and their smoking status at 6 months. And what we found was that in those who had a scan, they were twice as likely not to smoke, their diets were overall healthier, there was greater weight loss, and they were 3 times more likely to take medication. And when we looked at their blood pressure and their cholesterol levels, they were much lower than what they were in the standard of care arm. And when we calculated their risk score, again, it was much lower than what it was at baseline. So what does this mean? It's a good question, and I suspect that people might have some questions at the end, and I'd be happy to answer. But essentially, the heart scan helped patients understand what their risk was in the future. It helped them understand that maybe they weren't as healthy as they thought they were, and it led them to adopting a healthier lifestyle behaviours. It made them more willing to take medication to help prevent against heart attacks. Now, the caveat to all of this is, as much as we were very impressed with our patients and the results that they achieved, we do not know yet whether or not this strategy reduces heart attacks. And the study is ongoing, and it will require a period of follow-up to see whether or not these changes can reduce the risk of heart attacks for patients. I'd just like to acknowledge my co-authors and my supervisors. Special thanks to Professor David Newby and Professor Williams, who were invaluable. And of course, I would like to thank the patients who kindly participated in our study. And the final thanks I have to say is this study was entirely funded by the British Heart Foundation, for which we're incredibly grateful. And the study, if anyone wanted to read a little bit more about it, and it is a little bit more technical because it is written for a medical audience, can be found using the link below. And I will stop here.
Thank you, Mike. Fascinating stuff. And now I'd like to introduce our final speaker, BHF's very own Dell Stanford, a senior dietitian with a wealth of experience in supporting people to lower the risk of heart attack. Dell, if you'd like to join me, I have some questions for you. Good evening.
Hi, thanks, Fergal.
So, Dell, we know that a balanced diet is important for heart health, but why is the type of fat we eat so important?
Great, thanks. Good question. I just want to start by saying thank you to Helen. I think she's pretty much done my job for me. All the dietary changes that she made were fantastic, and she lost weight, so she did the whole thing. So congratulations and thank you. My job is done there. But yeah, I think before we talk about dietary fats, I just wanted to emphasise how important it is to consider the overall balance of your diet rather than just focusing on individual foods or nutrients. The Mediterranean diet, for example, is an example of a sort of an eating pattern that has lots of fruit and vegetables, lots of whole grain carbohydrates, carbohydrates. In fact, 2/3 of the diet that we're recommending people to have comes from plant-based foods. That's fruit and vegetables and the whole grains, with smaller amounts of lean protein from meat and fish and eggs and plant-based proteins, and smaller amounts of dairy foods, and sort of even smaller amounts of unsaturated fat. So that's sort of a healthy eating pattern that we know is associated with reduced cardiovascular disease risk by reducing cholesterol, helping people to achieve and maintain a healthy weight. It's really important that you sort of look at your overall diet. However, despite sort of ongoing controversy and misinformation, we know there's good solid evidence that having too much saturated fat in your diet raises your blood cholesterol level, and having a raised blood cholesterol level increases your risk of heart disease. So where do we get saturated fat from? Well, it's mainly foods of animal sort of origin, or it's not exclusively from animal origin, but mostly it is. So it's fatty red meats, it's fatty meat products, butter, cream, full fat cheeses, and the products that are made from those ingredients, like things like biscuits and cakes and pastries, ready meals and fast foods tend to be higher in saturated fat. The exceptions to the rule are coconut and palm oils, which are also high in saturated fat, and as far as we're aware, behave in the same way as saturated fat from the sort of animal products. So what we know is if you replace some of the saturated fat in your diet with unsaturated fat, it helps to lower your cholesterol level. So where does unsaturated fat come from? Well, it tends to be plant-based fats. So it's unsaturated oils such as olive oil, rapeseed oil. Vegetable oil is normally 100% rapeseed, and so that's included in this. Also oily fish that contains the long chain polyunsaturated fats, nuts and seeds and avocados. These are all kind of high fat vegetable sources, but they are actually high in unsaturated fat. So an example of making these changes would be if you had a nice piece of French baguette and you normally put some butter on it. If you were to choose a nice wholemeal baguette and dip it in olive oil, then you're directly swapping saturated fat for unsaturated fat, and that contributes to lowering your cholesterol level. So the kind of main message here with fat is to try and do the swaps from saturated fat to unsaturated fat. That's not to say you can never eat butter, but really, if you're having a healthy, balanced diet, you can only eat it in very small amounts, very occasionally, and the main part of your fat should be the unsaturated fats.
Okay, I'm delighted that you're reflecting on Helen's taking up all of that already. Well done, Helen. So what other key dietary habits are important for our heart health?
So yeah, I mentioned about the sort of general balance of the diet, but there are some key things that are really important. First of all, eating more fruit and vegetables. The aim is for us to have at least 5 portions of fruit and veg a day. A portion is about a handful, and actually, only about 17% of the adult population in the UK achieve that. Most people are eating about 3.5 portions of fruit and veg a day. I don't mind if they're fresh, frozen or canned, as long as they're not canned in salt or in sugar, sort of syrup if it's fruit. Canned in water is good, and they all count towards your 5 a day. Fruit and vegetables are low in fat, high in fibre, high in protective plant chemicals, high in vitamins and minerals, and they fill you up for not many calories. So they're really useful things to have more of. And honestly, if you only took away one message from today, that's definitely going to be one of them for me, because it really does help fill up your plate and fill you up for fewer calories and less saturated fat. We've also mentioned whole grains, so things like wholemeal bread, whole wheat pasta and cereals, and whole grain rice. Really important. They're high in fibre, they've got more B vitamins than the white counterparts, and they fill you up. Something else that really is useful to consider, which again, we're not great at in this country is eating more pulses. So peas, beans and lentils. These are really good alternatives to meat because they're high in protein. So, but they're low in fat, high in the sort of fibre that keeps our bowels healthy and keeps us regular, but they're also high in soluble fibre, which helps to reduce the amount of cholesterol our body absorbs. So having, 2 or 3 portions of pulses a week is where we'd like you to get to. And it could just be, for example, if you make a chili con carne, you put less meat in it and double the amount of beans in it. So that way you're reducing your saturated fat and increasing you're still getting the protein. Nuts are also high in protein, but they are also high in fat, but it's unsaturated fat. So, if you can get some of your fat from nuts and unsaturated sources, then that's going to be helpful. About a handful of nuts a day is what we would recommend. If you've got a handful and you can't see them, so you close your fists and you can't see them, that's normally about 25 grams of nuts, unsalted, unadulterated, not coated in chocolate or yogurt or anything like that. Plain nuts, and try and eat them as sort of once a day if you can, but just in small amounts. Just a couple more things. Eating less sugar is really important, and these are all things that Helen mentioned. We are allowed a bit of sugar. It's about 30 grams a day maximum. This is added sugar. This is not the sugar in fruits. This is the sugar that's added to foods like biscuits and cakes and drinks. And it's about 30 grams a day, which is about 7 teaspoons. It sounds a lot, but when you consider a kind of, popular fizzy pop contains about 50 grams of sugar. So you can see how it's very easy to have more sugar than we need. Salt is really important. Too much salt raises blood pressure, and having a raised blood pressure is one of the risk factors of heart disease, as Dr. Mike explained. About 75% of the salt we eat comes from foods we buy in the supermarket, as opposed to the salt that we add to food and cooking. So cutting back or cutting out adding salt to your food and cooking is great, but we also need to be able to have a look at food labels so that we can choose less salty food. So things like bread, cereals, canned foods, ready meals, sauces, that kind of stuff are all higher in salt than anything you could make at home. That leads me quite nicely onto ultra processed foods, which again, I think have been mentioned earlier on. I think over 50% of our diets as a general rule are derived from ultra processed foods, which is shocking. And it is associated with raised blood pressure and other risk factors for heart disease. So eating minimally processed foods is where we want you to get to. And that means doing more home cooking. It means cooking things from scratch. Your tomato sauce from pasta, fry an onion, bit of olive oil, a tin of tomatoes, and you've got a pasta sauce, and it'll be much lower in salt, sugar, and any additives than anything you buy in the supermarket. Oven chips will have added salt and additives, but if you chop a potato up, brush it with olive oil and stick it in the oven, you've got sort of a non-processed chip, as it were. So that's the sort of basis of the principles of healthy eating. But I would like to say that I don't think healthy eating is just about personal responsibility. The modern environment that we live in makes it much easier to eat more than we need and to move less. So I think the government and the food industry have a good role to play in making healthier choices the easiest choices.
Okay. And Helen, Dell mentioned walking, but how important is physical activity in keeping our hearts healthy?
Yeah, really, really important. I love the way that Helen said that each day she just walked an extra lamppost distance, and that really is, it's a really good thing to gradually increase your exercise intake, if you're not doing much exercise at the moment. So we all know that exercise is good for us, but actually it's because your heart is a muscle, and you need to use your muscles to keep them strong, like the rest of the muscles in your body. So using your heart keeps it strong. And so getting your heart rate up is using your heart, and it's working faster. So doing exercise that gets your heart rate up, gets you a little bit hot, gets you a little bit pink, and gets you a little bit out of breath is where you want to be in terms of, giving you that cardiovascular exercise and cardiovascular benefit. It doesn't have to be classical exercise, you know, going to the gym or joining a squash club. It can just be walking. It can be doing the garden. It can be doing housework, anything that gets you a little bit out of puff. And what we recommend is about 150 minutes of exercise per week. You can break that up however you want, 30 minutes 5 times a week or 10 minutes 15 times a week. We don't think it makes a lot of difference as long as you're actually doing the amount. Find something that you enjoy. Always warm up, start slowly. We start a car in first gear, not fifth gear. So start slowly, build it up gradually, and listen to your body. You want to be, we call it the talk test. So I've got this natty trick of, if I'm going on a walk with a friend and we're at the bottom of a hill, I always ask her a question so I don't have to talk on the way up the hill. But I can always assess how healthy her heart is according to whether or not she can answer my question. So if you can talk and walk at the same time and you're going uphill and getting a bit out of puff, that's where you need to be. Really, the optimum exercise is when you're, you know, all of those things I said, a little bit out of breath, a little bit pink, a little bit hot, but you're still able to hold a conversation. That's sort of the optimum cardiovascular sort of exercise. If you're pushing yourself too hard, you're going to stop. And that means you're not going to get your full exercise session. So if you're in any way worried, or you're getting symptoms, or you've had heart disease in the past, or you've got heart disease now, and you're worried about it, speak to your GP or speak to your cardiac rehab program. I noticed there was some information in the chats about emotional health and well-being not being part of the sort of, you know, the recovery process after heart disease. Well, you will get that if you attend a cardiac rehab program. You'll get exercise help, you'll get dietary help, and you'd get emotional health and well-being help. So it's all of those things in a package with cardiac rehab. So if you have had a heart event and you haven't had cardiac rehab, find your local one. We've got a cardiac rehab finder on the BHF website, or go to your GP and ask to be referred to your local cardiac rehab program. Exercise is really important, but it needs to be something you enjoy doing and something you can carry on doing every day.
Yeah, thank you very much. Just one further point. It strikes me that's about getting to know your own body, isn't it?
Yeah, I think it is. And we all have different fitness levels. So we'll all be slightly different. We call it a Borg scale. How far you get on the Borg scale, that's a rate of perceived exertion when you're just at your cardiovascular best, is going to be different for everybody. And so you have to listen to your own body, and you have to do something that suits you. I started running once to be with my son, and I got to the end of the street and pulled a muscle, and I haven't done it since. I just walk now. Walking's just as good.
Great, thank you very much, Dell. Now we'll welcome back our other two speakers, Helen and Mike, for the Q&A session. And if you have any questions you'd like to put to our panel, please pop them in the Q&A box now. But you've all been busy actually putting questions in already, so we're going to try and do it on the basis of most upvoted. And this one at the top is the most upvoted so far. And I think there'll be, all of you may want to share in this one. So the psychological damage done following a heart attack was harder to overcome, says this anonymous guest, than recovering from the heart attack. There doesn't seem to be any post-attack mental health help. This should be part of discharge from hospital. Do you know if this is something that will be offered to patients in the future? So there's this specific question here about what advice could be offered. But can we have a little chat about the psychological damage too?
I asked for some support when I was in hospital, and that seemed to flummox them somewhat. And I did get I think she was an occupational therapist, sent to have a session with me. But actually, I probably needed something a lot deeper at that time. And I did eventually, over a year after my heart attack, I organised some counselling for myself. And I only had 3 sessions. That was fine. And you know, what I needed to do was the bit that I didn't do when I was first in hospital. I cried. And I think it's the only time I've cried. And I think it was about evaluating myself as a person who wasn't 100% fit. So I think it's important.
So Mike, the psychological, Dell, you're going to come in?
Yeah, I just wanted to jump in there and say that, I think it's a really big part of your rehabilitation, that the emotional health and well-being side of it. And I mean, it depends where you are in the country, what's on offer to you, but almost all, well, it's part of their strategy. Cardiac rehab programs have to provide emotional health and well-being, or refer you on to somebody who can help. So for the person who put that in the chat, I would urge you, if you've had a cardiac event, then you should be entitled to some cardiac rehab help with that.
Okay, Mike?
Yeah, I think I agree entirely again with Dell and Helen. I think everyone has their own style as a physician, and I'm sure there's lots of people there who maybe have had heart attacks and they felt very supported, and maybe others who've not, and it's a spectrum. I think sometimes, Helen, you really hit on a really crucial point about a heart attack, and that is there's no warning. You don't know when it's going to happen, and you have often been perceived as being incredibly healthy up until that time. And actually, not only is it the event, because you feel that the event's been looked after, you don't have chest pain any longer, but you've now gone from being, at home with no concerns about your health, to being aware that something might happen, something might change, and that does sit psychologically quite heavy for some people, and they often do have this sort of residual fear that something might happen. In Edinburgh, we're quite fortunate where we have an excellent cardiac rehab team, but we also do try and follow up all of our heart patients in the cardiology clinic to have a discussion about their future risk and what we can do to prevent it. Now, I would say that probably most people feel that they can't spend as much time with patients as they would like. And I think, speaking to you just the other night, I think that was the impression that I also picked up from you, Helen, and you actively sought your own counsel. So I suppose I'm maybe going to put you on the spot, and I apologise for doing it, but from me as a doctor, when I look after patients, what would be helpful for me to do or be aware of that would maybe make their journey easier, or to signpost them in the future?
I followed all the cardiac rehab program that was offered to me, and it didn't seem to offer counselling. But actually, it's probably a year, 2 years on, that I would really welcome somebody telling me, you're doing the right things, it's okay now, you've reduced the risk. And there's no capacity for that. And I understand that the health service is overwhelmed with things to do, but it would mean a lot to be told now that I'm healthy. And because part of my problem probably was being out of area when I had the heart attack. So I'm not currently, I haven't seen anybody since I had the heart attack at the end of June 2023. I was signed off at the end of August 2023, and I haven't seen a heart specialist since. And I would really welcome that. And my last visit to the GP was asking for just that. Could I please be referred to somebody just to have a look at how I am? I know I'm doing all the right things, and particularly having had a pain-free heart attack, how will I know if I'm having another one? How will I know what my risk factors are? Well, I know what the risk factors are, but how will I know whether I've reduced my risk? Okay.
Thank you, and thank you to the questioner as well. Mike, for you, if I've had a cardiac arrest, have I had a heart attack?
Yeah, good question. This comes up quite a lot, and actually, that's something I'm often having to correct my mum and dad about whenever they're giving me the family updates. Well, so I suppose it depends on the cause. So a cardiac arrest is not synonymous with a heart attack. So a cardiac arrest is when the heart goes into a lethal arrhythmia, which is unable to sustain the pumping action of the heart muscle, and that causes you to lose consciousness, and you either need chest compressions with a CPR and a shock. Now, some people will have a cardiac arrest in the context of a heart attack, so the two can be slightly overlapping, but having a cardiac arrest is not the same as having a heart attack.
Okay, and just spell out, because there's another question here, just spell out the difference then fundamentally between a cardiac arrest.
Yeah, of course. Well, Yeah, so if you think of it, a cardiac arrest is when the heart muscle is no longer pumping, and the heart attack is the muscle is still pumping, but the blood supply that's going to the heart is reduced. So it might not pump as well as what it ordinarily would, but it's enough to sustain life.
Okay, and sometimes the little one I would use just when is one's electrical and the other's plumbing, but that's
that's
a very fundamental version. What's that? I'm no expert, but that's it gets me over a hump sometimes when I'm talking to people in that. So just a specific one. Can you dissolve plaque? This is Tina Jarvis is asking this question. Can you dissolve plaque, or once it's there, is it there for life?
Yeah, great question. Comes up a lot. So my stock answer for many years was that once plaque is there, it's never going to disappear. But we do know that plaque characteristics can change. So there are some features of plaque that when we do heart scans, we can say that type of plaque is higher risk of causing a heart attack than other types. And we know that from recent studies that when you take preventative medication, the plaque type can change from a high-risk plaque to a low-risk plaque. Now, the plaque itself doesn't disappear, but the risk of it causing a problem for you is so much lower after making lifestyle changes and preventative medication. And that having the plaque itself doesn't cause a problem. The problem arises as if there's a rupture and an acute blockage of flow of blood, or if the plaque is significant enough it causes symptoms when you're exerting it yourself. So I've tried to be quite clear there, but let me know if I've not answered it as well as I should have.
There's a question coming in. It's next up voted for you, Mike. It's just, what's the next steps for your research?
Yeah, good question, actually. So from the study that we've done, we really need to follow people up over a period of time. Now, the study is classified as sort of primary prevention, and the rate of heart attacks that happen in a primary prevention study don't happen very quickly, which is good news. We don't want lots of people having heart attacks. So we need to follow these people up for between 5 and 10 years to get an idea of if the intervention of using a CT scan or a heart scan to guide medication and lifestyle advice can reduce heart attacks. We need to follow those patients up before we can implement that into clinical practice. So this isn't something that would be offered as standard care at this moment in time.
Okay. Just for the audience, I'm just going to signpost you at this point before we go to the next question. But you can look at our risk factor hub. That's in the Q&A. Read our 6 top tips for lowering your blood pressure. That's also in the Q&A section. Foods to avoid with high cholesterol. And you can read more about Helen's story as well. Helen, what was the most challenging part of your recovery?
Ooh. Well, it wasn't changing my diet. I found that relatively easy. I think the walking, it was a change of lifestyle because my husband went for regular walks. He's much healthier than I am. And I didn't go with him. And sometimes I didn't want to walk. It was raining. I didn't want to go out. I didn't even want to do the short walk. And it's had to be a change of my head, really, about, well, I am going to walk. It's not the most wonderful day, but it's good for me. And I think it's changing my mindset.
Okay. From Sneha Badia, what do you think is the most common symptom of heart attacks that people often dismiss? Mike, maybe that's for you, but Dell, you'd hear some of this too.
Yeah, I think classically people expect chest pain to be really, I think we call chest pain something that people expect to be, there's no doubt you're having chest pain, but actually the most common symptom that people describe when they're describing chest pain is a tight band across their chest. So it's not a pain that you would get if you stub your toe or if you have a headache. It's a pressure, and that's often what people say. So the most common symptom that people have is chest pain, but it's never a type of pain that they expect. And Helen has mentioned that, you know, she wasn't feeling quite right, but during her story, she described something where she didn't feel quite right and she did feel a discomfort in her chest, and that's classic. And actually, people often temporalize that symptom where we say, well, it's not. We'll see what happens. I wouldn't do anything because it's just a little bit uncomfortable, and it doesn't get better. And often people aren't quite sure. We're always in a situation whether we should phone an ambulance or call for help. But that's certainly the most misinterpreted symptom that I often see in clinical practice.
Okay.
Mike,
Go ahead,
doesn't the when women experience heart attacks, they have slightly different symptoms, I understand. And I always remember we get a lot of jaw pain in the women patients at cardiac rehab, sort of pain around here in their jaws.
Yeah, so that's something we often do get referred pain. So I think this is something that's been explored quite a lot recently. And when you look at large volume studies in women who present to the emergency department, they actually present with the same symptoms as men, but often they're misinterpreted by the clinician that assesses them. And that was a big study that was done in America. So actually, the rule that we sort of try to appreciate is women actually do experience heart attacks similarly to men. But sometimes they're not interpreted in the right way, and that's where that sort of information has come from. And that would probably reflect what I see in clinical practice as well. Yeah.
Okay. So after heart attack, this questioner wants to know about cholesterol testing. How often after should this be done? Quarterly, biannually, annually?
Yeah, great question. So until about 2 or 3 years ago, when people had a heart attack, we only really had one therapy for lowering cholesterol, and that was statins. And once you had a heart attack, you were on the highest dose statin or the highest dose that you could tolerate. And people would make lifestyle changes. Now, realistically, we see the maximum effect of your cholesterol within about 3 to 6 months after taking that statin. But we would check it, and actually, once you were on that medication, there was very little else to add in. In the last 2 or 3 years, there's been an explosion of lipid-lowering therapy. So actually, if you've not got optimal control at 6 months, then I would check your cholesterol again in 3 months, and if it's still elevated, then I would think about adding in extra agents. And once you get to a part where you're established on therapy and you know that your cholesterol is stable, then you probably can be a little bit more relaxed about it. So the answer is there's no hard or fast rules. It depends on the individual, depends on what the lipid profile was like before the heart attack, after the heart attack, and how well it responds to therapy.
Yeah. And what are the risks of having a second, even a third heart attack after a first one?
Yeah, great. Well, I think you made a great point earlier, Virgil, when you introduced the show, and that was the risk of, more and more people are surviving heart attacks, and the actual risk of having a further heart attack is as low as it's ever been before. Our understanding not only of coronary artery disease but bystander disease and getting people into good medical therapy is never been better. Now, I can't give you exact numbers, and it wouldn't be fair for me because sometimes people come in and we have one blocked blood vessel, but in Helen's case, she had a number of blocked blood vessels, and that often is what we see. And those patients do need a bit more intensive input. Whereas if you come in with one artery that's blocked and the rest of your arteries look well, and we open it up and put a stent into that, the risk of a further heart attack is exceptionally low.
Okay, thanks. Thanks. Dell, how does alcohol affect the risk of having a heart attack?
Yeah, good question. So it's interesting because historically, moderate amounts of alcohol, and in particular red wine, has been associated with improved cardiovascular disease, sort of protection. But we know that's not the case now. There is no safe level of alcohol intake at all, for cardiovascular disease or other chronic diseases like cancer. So the recommendation is to have no more than 14 units of alcohol a week. That's approximately, a sort of a medium glass of wine 6 times a week, or a sort of a fairly average alcohol percentage beer pint about 6 times a week. So that's a maximum. We're not suggesting that you should try and achieve those amounts if you don't already drink, but it's that, and it's to do, I mean, alcohol has inflammatory properties, and there's lots of reasons why drinking too much alcohol is not good for you. For lots of chronic diseases, it's not good. But I think that keeping within your 14 units is fairly standard, and that's a safe thing to do.
Okay, thanks. Where did that hour go? Hard to believe. Helen, thank you so much for sharing your story and your growing knowledge about risk and what you've shared with us. Mike, thank you so much too, and Dell. If we haven't managed to answer your questions, we encourage you to call our Heart Helpline and speak directly to one of our cardiac nurses. Heart Matters Live is a free quarterly Q&A series, and we strive to produce the best live events possible. Your feedback and comments are crucial to help plan and develop future events. So we ask if you can complete the survey that you'll receive in an email in the coming days. All of our incredible research is funded by 100% by you, the public. If you were inspired by what you heard today, then all donations to support our life-saving work are very much welcomed and appreciated. There's a link to donate in the chat box should you wish to do so. This edition of Heart Matters Live was recorded and will be available on our YouTube channel from next week. Our next event will take place on the 4th of November and will be focused on living well with heart failure. Register now using the link in the chat box. Thanks again for joining us, and goodbye.